everyone, and thank you for attending today's webinar, Thoracotomy Implant Considerations for the HeartMate 3 Left Ventricular Assist System, LVAS. The presentation here is full of three experts, and I want to share some background on all of these gentlemen as we get started. First off, we have Dr. Igor Gosev on board. We have Dr. Akinobu Itoh here, and also Dr. Robert Kormos on board. Really looking forward to an interesting and lively discussion looking at a range of viewpoints regarding this surgical approach. I want to share with all of our audience, and we've got a big turnout here today. We appreciate all of your time. Faculty will receive honorarium for this presentation. The views and experiences expressed during this presentation are those of the faculty and do not necessarily reflect the views of Abbott. But right now, we do have a lot of content we want to get to, and so I want to officially turn things over and welcome to our content here, Dr. Gosev.
Thank you. Thank you so much. I'm really happy to be a part of this amazing discussion. I think we're going to start by discussing setup incisions and cannulation for our less invasive implantation of the HeartMate 3 pump. I think after we've gone through our process of selecting our patient, after we've done all our preoperative rehabilitation, completed our CT scans, and decided what type of approach we want to have for the outflow graft part, we move forward with the setup in the OR. In our experience, we do place incision most likely in the fifth intercostal space. We do go straight down through the intercostal space into the chest. We do place a lap and push the lung away, expose the pericardium. We do the same on the right side where we occlude and tie mammary artery and vein. We use soft tissue retractor and special retractors that kind of mold to the shape of the ribs, so we increased our thoracotomy working space. We do put a pericardial sutures, and our practice evolved over time, so now we do smaller incisions and are more comfortable with less visualization. On the right side, as I said, after occlusion of the mammary vessels, we do place soft tissue retractor and special intercostal retractor where we and then expose our aorta. Our cannulation strategy is always the same: 25 venous cannula in the groin, and then usually 18 or 20 IOPA cannula directly in the ascending aorta. I think smaller cannulas or as small cannulas as your perfusionist is comfortable with are important because the space is limited in that right chest, and we want to preserve as much as we can for our side biter and our outflow graft anastomosis. Next step in the procedure would be coring, suture placement, and apical cuff fixation. So after we've went on heart-lung machine and we've exposed the apex of the heart, there are different ways that we can do these things. And then, again, Aki, my understanding is you don't spend a lot of time on a heart-lung machine. Do you do your apical cuff fixation on or off pump?
Yeah, usually sewing cuff attachment would be done before we go on pump, but we cannulate the heparinize fully, ready to go on any time, and then we place the sewing cuff with the beating heart before we go on pump.
In my practice initially, and practice evolved over the last 2 years, we did the core, then sew technique, and now during the video you actually see us using our coring technique that uses the Foley catheter that kind of helps us fixate that part of the apex that eventually gets corn. Here we actually emptied the left ventricle using one of the cardiopulmonary bypass vents, which then helps us not get actually splashed with blood sitting in the left ventricle once the core is done. As you see, exposure is pretty good, and after apical core is done, as you see now, we start by placing 4 corner sutures. We do use Pledgeted 2.0 Attibon sutures. We fix them to a ring and then complete the circle with at least 2 sutures in between them. Overall, we use anywhere between 12 to 16 sutures, kind of fixated to this, valve suture ring that you would use for regular valve surgery. Again, different ways to do things. In my practice initially, we did then put the sutures through the apical coring cuff, and then we would fix them using a core knot. Again, there are different ways to do these things. In Rochester, we would use a core knot. I think hand tying is perfectly fine. Most of the centers do that. Concern about core knots kind of impeding with the pump is not really something that's happening in our case. A lot of people use BioGlue. Initially, in my practice, I used BioGlue. Now we kind of shied away from that. I don't know, Aki, do you use BioGlue in your cases?
I do not use BioGlue at all. Any type of surgery except the LV aneurysm repair or something like that. But no, I don't.
Yeah, I think that's the way I'm moving these days. Apart from being expensive, there are some concerns about toxicity, and I think it's reasonable not to do it, especially if your sutures are nicely and well positioned. You should have no major bleeding there. The third aspect of the implant procedure would be pump placement and pump positioning. And after the apical coring cuff is in place, what we would do is connect the outflow graft to the pump. I would actually measure 13 to 15 centimeters on the outflow graft, and in that way, once the outflow graft is inside the chest, I kind of have the idea where what the length of the graft left in the chest is. In 2018 and 19, we would use a clip to prevent outflow graft from rotating. Now we have a new outflow graft that actually has solved this problem, and there's one step less that we have to do. Incision on the left chest should be big enough so you don't compromise a placement of your HeartMate 3 pump. Again, in my practice, we use soft tissue retractor that kind of keeps the fat out of the way. And once the pump is inside the chest, in my opinion, and in my practice, it was relatively easy to lock the pump in. I mostly use, or most of the time, I use a regular large cuff. I find just something I'm used to, but I think it's perfectly fine to use a small cuff if that's something you're used to. When it comes to tunneling the drive line, different ways to do this. Again, I use a small counter-incision just to the left of the xiphoid, where I then take the drive line down to the left lower quadrant. Again, different ways to do these things. I know some of the European centers directly tunnel drive line. I think as long as the whole velour is buried, we're in a good shape. Next step in our implant procedure would be outflow graft measurement and anastomosis within the right chest. Again, right chest incision is done in a second intercostal inner space. In our opinion, actually, the retractor use is very important because the space is minimal and very precious in this right thoracotomy. As you see, after measuring the graft to appropriate length, regular anastomosis is performed after side biter is placed on the aorta. As far as the tips and tricks, we now actually clamp the outflow graft through the left chest, and therefore this angle DeBakey clamp that used to hang from this small thoracotomy is out of the way. This is one of the initial videos in our practice where we still use the BioGlue. Now, these days we don't use BioGlue at all. After all the anastomosis have been done, the next step is to wean off cardiopulmonary bypass. And, there are different ways to do that. Some people come off completely and then start the pump. I gradually wean pump and start HeartMate 3. De-airing is a challenge in the bilateral thoracotomy or less invasive surgery approach. I know, Itoh, you have some other ways of doing this de-airing. I do just a small bore needle and create a couple of holes on the outflow graft that eventually are closed after the protamine is in. I've never had problems with air, but as far as the cardiopulmonary bypass wean parameters, I do use very specific parameters as far as the heart rate being over 100, blood pressure being over 80, using flow line on every case, and making sure that echo parameters of the pump wean are just right, meaning septum being bowed to the right and aortic valve opening every couple of beats. We do come off on a lower speeds. It's something that helps us with our very minimum amount of RVADs, I think, that we've placed. So our smaller patients come off at 5,000, and our larger patients are usually off at 5,200. I mean, I don't know, Aki, do you have any specific speeds that you like coming off, or you just kind of play by the ear?
For your question about the pump speed when we come off, I usually start somewhere around the 4,000 RPM on HeartMate 3, coming down on bypass machine and stop the cardiopulmonary bypass, usually somewhere between like 4,000 to 48 or 5,000 RPM, depending on the patient condition. Then more volume and blood pressure control, and slowly, gradually go up on the RPM, obviously based on the transesophageal echo findings with the atrial septum and the ventricular septum position.
Thank you. Yeah, we kind of do the same thing. Talking about hemostasis, drain placement, and chest closure, after weaning off the pump and decannulation, obviously reversing heparin with protamine, our last video will show parts of our hemostasis, drain placement, and the chest closure. I think placement of the drains so we don't retain any blood or fluid is very important. We do use 324 Blake drains, one in the left chest, one in the mediastinum, and the one in the right chest. We do also use a preclude membrane to kind of shield the pump from the lung and facilitate future heart transplant. I think in the end, we do not attach the ribs back. We just use number 2 Vicryl and approximate the ribs to prevent any lung herniation, and then we do skin.
Thank you very much, Igor, for that perspective, and we'll now move to Dr. Itoh and let him continue with his presentation.
Okay, thank you very much, Bob and Igor, and thank you for having me here for the webinar. It's a great honor to be and discuss about this with world experts. Always the question I get asked is rib space you're going to go to expose the LV apex. So you always use the ultrasound, on the operating table with the patients anesthetized and paralyzed. Then the diaphragm position on the ventilator may be different from the CT scan findings preoperatively. So always ultrasound and then drape off and then cut the soft tissue, and then again ultrasound to determine the intercostal space I go to. Then I usually do both the right anterior thoracotomy and upper hemispherotomy depending on the patient condition and the anatomical features. So this is a video for the right anterior thoracotomy. Go through I believe this is the third intercostal space, similar to Dr. Gosev, and ligate the right mammary, shingle the right rib, third rib, the proximity, the attachment to the sternum, and smaller soft tissue retractor. And I don't really necessarily use the special intubation tube, endotracheal tube. We don't really need any, single lung ventilation. So once, you expose everything, pull the pericardium, expose the aorta, and then once you go on bypass, obviously lungs are not coming into your field. Then LV apex, I think the rib space, which rib space you go to is very, very important unless you open up and go on pump, then you can move around the heart and the apex, determine the apex where to go to. But in order to place the thawing cuff on the LV apex, before you go on pump, you really want to have the LV apex right in front of your face. So this is the case, I think we opened up the fifth intercostal space, shingled the number 6 rib, and then placed the sutures first. After I mark with a little purple marker, then place the thawing cuff. And fixate the thawing cuff, make sure there is no bleeding around. Then core the LV using the Foley tension, counter-traction, and the regular sewing, regular coring knife. Then I always, at this point, the patient is already on pump, as you can see, and then make sure that there's no residual, muscle or any chronic thrombus if there is any, and just make sure your core is intact, and endotracheal, endocardial, trabeculae will be cleaned out completely. There's nothing to come into the pump or anything, or nidus for the thrombosis formation later on. So then usually, I do this outflow graft locked in completely, then guide the outflow graft tunneled to the right thoracotomy. Make sure the black line is on the top and not twisted at all. Then place the pump, this way. I think with the new connection of the outflow graft, you can place the pump first and then connect the outflow graft inside of the chest. That's also, I think, now an option with the new connection technology Abbott came up. This is a external additional hemostasis sutures. I had a little bit of a tear when I was dangling around the heart when I connected the pump. So that also need to be carefully watched and make sure that there is no bleeding around the thawing cuff after you place the pump. And the outflow graft anastomosis, this is something what I do, I clamp the graft and I turn up the pump to 45 so the pump is flowing against the clamp, so the graft will be expanded, and then make sure the pathway inside is fine, so then they determine the length of the graft. So you don't have to do anything, and it's right there, based on the patient anatomical condition, the graft length will be determined. And then the aortic punch is utilized, and just make sure that the aorta where we placed outflow is nicely trimmed and open, and then just finish the 4 proline continuation to the ascending aorta with a regular partial clamp on. And de-airing, as Dr. Gosev mentioned, this is for the partial clamp to come off. Then I usually use ascending aortic vent with the pump suction attached. If there is no space, this is another way to do it. Like it's a needle with the side holes and connected to the pump suction and put into the graft. And usually I place the pericardial pledget to the 5-0 to close the needle hole so that you don't have any bleeding later on. Then the right lung expanded. Make sure there is no pneumothorax or anything before the closure. Then the left thoracotomy, this is a hemisternotomy approach video. It's the same way, 5th intercostal space above the 6th rib. I think, moving on, like more experience you get, I think the incision can be smaller. But, I think Dr. Gosev's video also, the earlier video was, he had a larger exposure, and this is also, I had a really large exposure of the left LV apex. So that's something, I don't think it matters, either your incision is, 2 centimeter larger for DT LVAD patients. Rather, I think surgeons should be comfortable, exposing the LV or aorta in a safe way until he or she gets used to do this approach. So upper hemisternotomy, this is the left side of the patient we're taking this video. I just use a small sternal saw to do the reverse L shape upper hemisternotomy and to put a pericardium on the sternum, so that when you open the sternum, the pericardium will be pulled up and the aorta will really come up to your surgical view. So then the aorta is right there, so you can easily cannulate centrally, as if you do regular full sternotomy cardiac surgery. So this is, majority of surgeons are familiar with the mini AVR approach. That's the major benefit of the upper hemisternotomy approach. Also, the patient's aortic position, if it's medial, upper hemisternotomy is going to give you a lot of much better exposure compared to right anterior thoracotomy. So I usually decide based on the CT scan findings where the aorta is. Also, the deeper patients, I think upper sternotomy is better. Patients with a big chest and deep chest. So this is a driveline placement. I usually go through the intercostal space towards more medial, then come out just once with the counter incision, and then go back in and to the close to the umbilicus. So the driveline is not going through any intraperitoneal space or transverse colon. Then cuff attachment. This is a different case. I place the cuff first and then put the sutures along the cuff. Again, this is sole first and then core case. So this is beating heart before we go on pump. Place the cuff like this. So the cuff is relatively towards the inferior wall, so that the device will sit nicely pointing towards the left shoulder of the patient, right shoulder of the patient, and directed towards the mitral valve, not competing with the chest wall or anything. And then usually place the Gore-Tex. Now I predominantly use 2 millimeter thick Gore-Tex. This is aortic cannulation because the aorta is right there. This is exactly how you do with the regular heart surgery. And then the LVAS after the core. Carefully clean out the trabeculae or any thrombus if there is any.
Aki, do you think that you see better in that left ventricle through a thoracotomy than through a sternotomy? Because it's not kind of lifted up.
I'd say it's not better, but you can see, really well. The reason is that, depending on the patient body position, to see the LV inside, you really have to rotate the table to the right. And if the patient is heavy and falling off the table, you can't really rotate the table too much. So back to this video, outflow graft is carefully placed again with the pump on and expand the outflow graft to determine the length. And then similar way with the upper hemisternotomy, again, the aorta is right there. At this point, no stress, whatsoever when you do this outflow graft anastomosis upper hemisternotomy.
That is a great exposure. Which interspace do you usually go through, Aki?
Usually down to the third intercostal space. That's more than enough. Sometimes second is enough, And then this is a thick Gore-Tex membrane to the left thoracotomy, so that this can be a cushion between the device and the chest wall, which can reduce the pain where the pump is sitting at the chest wall.
No
so then
bleeding
closing
wires.
The sternotomy with wires.
Really, really great technique, Aki.
Well, doctors, you've gone over a lot of great information. It's awesome to be able to see these videos and hear your commentary over them as well, and the discussion on the different, techniques that you work on. And the first question I want to lay out was coming in just about the learning curve for implanting HM3 via thoracotomy. What was it for you, Dr. Gosev, your learning curve compared to other techniques and previous versions, et cetera? What was your learning curve?
Excellent question. And I think what we first want to be is safe. We are lucky that at our institution we had a very experienced minimally invasive surgeon that was very comfortable with the right thoracotomies. But I think for LIS implant of the HeartMate 3, I think it's perfectly appropriate to start with upper hemisternotomy, as Aki mentioned. I think incisions initially are bigger, pump times are longer, but at the end of the day, you want to do what's right for your patient. And in my experience, our longer initial pump times did not reflect our postoperative outcomes. In fact, actually, our outcomes were better than with the sternotomy. So I think it takes a while. I think it takes good 5-10 cases for you to be fully comfortable and for your team to be fully comfortable with what you do. I think Aki mentioned one very important thing. You don't have double lumen tubes, so you do have to kind of play with those lungs being in your way and kind of being comfortable pushing them away with your laps. But I think all that kind of sits in place after a few implants. Aki?
And Dr. Itoh, what about your team and your feeling of what the learning curve was to get comfortable?
Yeah, so it takes a while for the team to be comfortable, for sure. We started putting these things in back in 2013, 14. And initially people were like, what? Why are you doing what? What is this? Like, is that possible? That's where we started. But, with the experience of mini sternotomy AVR, people are familiar with this part. So I think for surgeons and also the staff in the operating room, to start with something they're familiar with, and then maybe just, one part, the left thoracotomy LVAS implant is not something what people have never done, then, combination with the upper hemisternotomy, if you're familiar with, then you can start from there. And also, again, I mentioned the size of the incision, especially the left thoracotomy, can be very generous, to begin with. And then, once you start comfortable doing these things, you can go smaller and smaller. But, I don't really think it matters even if your incision is, 1 inch longer or shorter, for those patients. That's not something what patients, can show off to the family or anything. So I think safety first is one thing, and you have to make yourself comfortable to achieve, this challenging surgery, so to speak.
I totally agree with you, Aki. I think benefit of the procedure does not necessarily come from the size of the incision, but probably from the preservation of the sternum and the pericardium. And even though it's not have been quantified so far, I think the centimeter here is important. Totally agree with you.
Doctors, you and your teams now have been doing this. We have folks on board, surgeons that are looking at potentially starting to implant HM3, and it's something they're considering. So again, kind of a best advice, something to think about before you start doing this that you would give to a fellow surgeon. What is it that you would recommend for folks that are starting to think this is something we want to incorporate in our practice?
I think patient selection is very important. I think you want to start with a patient that is in a good shape. I don't necessarily think you want to start with overly obese or too small of a patient to begin with. I think everything else that we would use as a good implant through a sternotomy, we want to use for as a criteria for a bilateral thoracotomy implant. I think obviously not having all our patients are sick, right? They are in heart failure and they need a mechanical device. So, by definition, they're kind of sick. But, we have different sizes, different RV function, different renal functions. And I think we should try to go with the patients that are less sick and slowly move towards bigger and sicker patients.
I agree with Igor. Yeah, I think majority of surgeons are very comfortable doing, sternotomy, HeartMate 3 implants. I can probably do, someone who never had any chest surgery, skin-to-skin HeartMate 3 procedure through sternotomy, full sternotomy within, maybe 2 hours, 3 hours. That if that's the practice that surgeons do, then this procedure, you have to have someone who can really assist you, work on the other incision, and it's a really teamwork you need. So definitely challenging situation, so that you have to have a good patient, to start with and to make the team comfortable. So patient selection is very important. You don't want to do any obese patients or patients with a large breast or really deep chest and things like that. Those patients are someone you can probably do later on.
Dr. Itoh, did you find that you had to do anything different to prepare your team to support these cases?
First of all, we do switch, sternotomy and thoracotomy. If that's something what we do, then nursing staff in the operating room are so confused. So is this thoracotomy? Is this sternotomy? Eventually what we did is just made the thoracotomy pan and the sternotomy pan, like a LVAS pan, like everything mixed together. So we can go switch back and forth. If we have to do sternotomy without telling them, we can do sternotomy. If we have to do thoracotomy, we can do thoracotomy without telling them. So that's one thing, you may want to consider to get the OR ready for you. Also, the setting up the patient is, as I mentioned a little bit, for left thoracotomy incision, I rotate the table really well to the right side. For the first case I've done this, like 5, 6, 7 years ago, my patient almost fell off the table. So since then, I use the bean bag underneath and fix the patient really well on the table, so I can rotate the patient body so I can see the LV really, really well. So those are the things you really have to plan and prepare with our staff to make the surgery very, very safe.
Yeah, I totally agree with you. You want to make sure your staff is fully comfortable. You want to make sure that your staff knows the step of your procedure. I think it starts with booking the case, and we do book in detail, and also having all the appropriate instruments. And I think I mentioned I feel strongly that having appropriate retractors for right and the left thoracotomy definitely helps with procedure and helps with implant technique. But, having open communication, being on board, having multiple pauses through the case where you discuss the parts of the procedure and what comes next always helps. We have that practice in our OR, and, communication between our anesthesiologists and scrub nurses and perfusionists is really, I think, excellent.
Dr. Gosev, I want to come back to a comment you made about the sewing cuffs that you prefer, and why you had mentioned that some people might prefer to stick with a mini cuff. So again, just clarification, what is your preference, and why is that your preference, and what's the difference between some of those options?
I think both cuffs are a good product. I am personally more comfortable with a larger cuff. Most of my procedures are done with a large cuff. I do interrupted sutures, therefore, for me that is somewhat easier. I would think that people and surgeons that actually like to run their sewing cuffs, I can see how they can benefit the smaller cuff because that's easier. To a degree, I think it's important to be cautious of tissue bulking on the smaller cuff, because I think sometimes you could get into trouble with locking the pump. I had that once and was not really the greatest moment. Therefore, larger cuff for me is something that I'm comfortable with. I can, go through those motions relatively quickly now, and that's why I use it.
And Dr. Itoh, I don't know if you got a chance earlier to comment on your preference there. Would you like to comment?
I usually use large cuff with the metal ring. I've used a mini cuff a couple of times for full sternotomy patients. I think both cuffs are good. Yes, for running sutures, it's better to use mini cuff. But the most the biggest benefit of the large cuff with the metal ring is that I use my all fingers to lock the device deep down, so push the HeartMate 3 with my thumbs, and then other fingers are hooked under the metal ring, so I can push the HeartMate 3 all the way deep in and lock it. So that'll really confirm the positioning of the HeartMate 3 into the cuff very, very well, which is not really possible with the mini cuff. I think this is more important, with the left thoracotomy approach, especially with the limited surgical view and everything. And if your HeartMate 3 is not all the way deep into the sewing cuff, obviously, not only you can lock the HeartMate 3, but also you struggle with the device locking process in the limited approach.
One question that came in several times from several folks. I'd love to get both of your comments. Dr. Gosev, we'll start again with you. Have you observed differences in procedure time with this approach? What can you tell us on that front?
That's an excellent question. And as we said, and going back to learning curve, every beginning is somewhat hard and it takes time. So our initial pump times, our initial OR times are long, or were longer. As Aki said, you can do skin-to-skin HeartMate 3 for maybe a few minutes less than 2 hours. With the bilateral thoracotomy approach, it does take somewhat longer, and 130 pumps in, now I can finish, case skin-to-skin in 3.5 hours. So it still takes some more time, but I think it's worth the time, and I think the benefit that we see in a post-operative period is significant. And as I said, those longer OR times and longer pump times did not negatively reflect on our post-operative outcomes, such as bleeding or intubation times, for instance.
Dr. Itoh, comments on timing?
So in my practice, I also do the left thoracotomy approach for redo patients who had a previous coronary bypass or valve procedures. For those patients to go through full sternotomy, redo full sternotomy, dissect out the whole heart, and the LVAS implant, and then dry up and close the chest, which takes a long time, especially for the dry up phase. Hemostasis, you have oozing, bleeding, and sometimes, we pack the chest and then spend overnight and go back on the next day and wash out and close it up. So when you consider that, you do left thoracotomy approach in either upper hemisternotomy or right anterior thoracotomy, we see a lot of benefit, because once you put an LVAD in, then sew a graft on, and then minimal dissection around the heart. Then once you put a protamine in and dry up, and you can just close it up. So you don't have to really go through all the hemostasis process or, packing the chest and going back to the OR on the next day. Nothing like that. So I see more benefit on redo patients. Although we need to think about where we place the outflow graft in the redo chest, with the adhesion around the heart. It's a whole different strategy we have to think about. But that's one of the major benefit of this approach.
We have a question in here about pain management, and do either of you have you made any changes to how you help your patients manage pain after the surgical approach?
Oh yes, I think it's a great question, and it's a very important one, because we know thoracotomies. People that have thoracotomies do have a significant pain after surgery. We have a comprehensive pain protocol at University of Rochester Medical Center, where we use multimodal analgesia post-surgery. We use IV Tylenol. We do use gabapentin once the patients can take their POs. And also we do pain blocks. We do at least 2 pain blocks on post-op day 0 and post-op day 1. Where the first one is done hopefully a couple of hours before the extubation, and the other one on the first post-operative day. We find those things really helpful. Just recently, we've had some discussions about epidural, and I know, Aki, you mentioned you have some patients at Barnes with epidural epidural catheters being placed for LVAD surgeries. But it is a big deal. It does require a very close monitoring. We do have multimodal analgesia, as I said, and I think some of the things like ice or local topical anesthetics can really help as well. So that's kind of where we are at, and I think most of our patients do well, and by day 3 or 4, their pain is kind of okay and under control.
Anything to add, Dr. Itoh?
No, he said everything. Yeah, we also use a combination of intercostal block and the topical local anesthetics, oral medication post-op. Majority of patients complain, like, the left chest thoracotomy incision pain for the first few days, but beyond that, the benefit of, no sternal precaution or minor sternal precaution because for the upper hemisternotomy actually helps a lot for the patient to recover.
That's an excellent point, Aki, because sternal precautions are really Achilles heel of sternotomy, and when the patients are in heart failure and already very sick, to tell them that they can't use their arms to get up or move around is really a big deal. And I think I just want to add that in our experience and in our postoperative monitoring, we have not noticed any significant chronic pain. There was we had that concern, but it actually did not happen. So.
On behalf of Abbott, we would like to thank our audience for tuning in today, and we look forward to having you on more webinars in the future.